First of all, I'd like to thank you all for joining our third Survey Venous Forum, which mainly address the best practices in management of hemorrhoids and chronic venous disease. And today, it's our pleasure and privilege to have our chairman, Dr. Khalid Farag Rifai. Dr. Khalid, he is a family medicine consultant in specialized polyclinics from National Guard Hospital, Jeddah. So please join me to welcome Dr. Khalid Rifai.
Assalamu alaikum. First of all, I would like to thank Survey Company for this scientific meeting. And we have only two lectures with two expert doctors. We will talk about today and best practice in the management of hemorrhoid and insufficiency, venous insufficiency, varicose vein. Dr. Hani Mussallem, it's a consultant vascular surgery in Faqih Hospital, and Dr. Samir Raghib, he's a consultant also in the head of surgery department in the United Doctors Hospital. I would like to thank everybody to attend, and we are so sorry for late lectures. Everybody are feel to ask any questions about after the finishing the lectures. Okay, Dr. Hani will start. Okay.
السلام عليكم. أنا دكتور هاني مسلم استشاري جراحة الأوعية الدموية بمستشفى سليمان الفقيه. As you see, this is my faculty of medicine at Montpellier. This faculty of medicine was founded 800 years ago. Still the same building, the same walls, everything as built at that time. Now, we have a new guidelines. It was appeared in 2018. It's management of chronic venous disorder of the lower limbs. This guidelines according to the scientific evidence. So, overall prevalence of chronic venous disease from class 0 to class 4, I will explain what this class 0 until 6. Okay, it's about 45.6%. Prevalence of chronic venous disease with visible signs only from class 1 to class 6, it's about 38.3%. Then this guidelines give us a higher in female than male. Now, chronic venous disease is a very common problem with varicose veins affecting more than 25 million adults in the United States. It's a huge number. More than 6 million with more advanced venous disease. We have here a study from Edinburgh Vein Study. They did a study on the patient about 1,566 subjects with duplex ultrasound for reflux of the chronic venous insufficiency. They found 9.4% of men, 6.6% of women, and 21% in men more than 50, and 12% in women more than 50 years old. Look for these two images. For the venous insufficiency, we have two categories only, either only varicose vein or chronic venous insufficiency. The patient come to us, simply, it's simple with varicose vein. When started this patient to be advanced in the CBOT, this is the classification I will talk about, Patient came with leg swelling, skin color and texture changes, then ended by venous ulcers. Dysfunction or incompetence of the valves in the superficial veins in the superficial venous system also allows retrograde flow of the blood. We will see this is the normal valve closing. This is during the blood going from peripheral body to the heart. This is complete closed. This is still open, that means insufficiency, incompetence. And this is the damaged valve. Look, the blood stay down beneath the valve. That means the blood going up and down, and more stay in the leg, what's named stasis of the blood. We have also incompetence of the valves, competence of the veins and competence of the valve, competence of the perforant also. Incompetence of the valves of the superficial veins with reflux has been shown in less or equal 90% of the patient presenting the chronic venous disease, with reflux in the mainly in the great saphenous veins. In other name, it's long saphenous vein. According for 70% to 80% from the study. And in equal 84% of those presenting with venous ulcers. When ended by a valve like that, the blood going up and down and morely stasis and down, that means the venous pressure will be increased in the lower limbs and can do for disease. So we will talk now about the symptoms. Most symptoms are mild and not limb-threatening. That means the patient with the venous insufficiency, he not will dying from that, and he will not going for amputation from the venous, chronic venous insufficiency. Patient came to your clinic complaining from heaviness, swelling, and pain. Symptoms is the complaint. Heaviness, swelling, and pain is his objective. He told you, I have found tell, and what you are going to see in this patient. You may feel heaviness in the affected limb as well as swelling and pain. Sometimes there is a darkening of the skin. Here, just only the pain and small venous insufficiency, and oh look, this is the just only varicose vein. Varicose vein, enlarged and twisted veins close to the surface of the skin and are signs of milder form of venous disease. You may have feeling, aching, heaviness, and pain. Causes. A chronic venous insufficiency can be caused by congenital absence or damage of the venous valves. Sometimes I received in my clinic patient, young, teenage, even less than 13 years old, with varicose vein. This is mainly due to congenital disease of the valves in the veins. Venous incompetence due to thrombose or due to thrombus formation as favored by the Virchow or Virchow triad, venous stasis, hypercoagulability, and endothelial trauma. Varicose vein rarely are associated with the development of chronic venous insufficiency, as I said. If you remember the image, there is a vein and chronic venous insufficiency, both different. Patient came to you with just varicose vein, patient came to you with the advanced sign and symptoms of chronic venous disease. Most cases of venous insufficiency are related to reflux through a superficial veins. You saw the patient and you sent the patient to study for venous duplex ultrasound, the result came to you with there is a superficial or a saphenofemoral junction or popliteal femoral junction insufficiency or incompetence. That means this is the reflux. We stay always in the superficial. When you're going deep for a problem with the deep venous system, that means we are going to the chronic venous insufficiency. We will go into the diagnosis to test a new classification of chronic venous disease, which is the most important of this lecture, how to do your diagnosis. Everybody can talk about varicose vein. Everybody can talk about the chronic venous insufficiency. We will talk about the degree, the level, the stages. It's a big difference in the treatment of every stage. Okay? The test a new classification of a chronic venous disease based on the clinical etiology, anatomy, and pathophysiology. Isn't clinical, etiology, anatomy, and pathophysiology. This is our 3 or 4 words. It's given us a SEEP. So this SEEP can be divided to 4 or 6 categories. It depends on your patient. In a series of the patient by using objective tests to establish your diagnosis. It's very important, this category. Test may be recommended by ultrasound Doppler, CT scan for the abdomen, mainly for the abdomen, to see if there is any compression in your veins or if there is malformation. Sometimes the vein, the iliac vein, going between the iliac artery and the vertebral column. So if you have this problem, you must correct your vein, either bypass to the vein or by a stent. Otherwise, if you will remove or doing a stripping for your saphenous vein and you have this problem, the patient come back a few months later with other hugely collateral vein on the skin. And venogram. If you look for this is the, usually in the ultrasound, if you see this red color, that's mean a arterial blood. But in fact, this is not arterial blood, it's a venous blood. Due to stasis and the blood going down always, not going up to the heart, by tubal ultrasound machine, it gives you as artery. So be careful for that. Flow in the direction of the feet is because of incompetent valves as shown in red in the color image and above the baseline in the pulse Doppler. I named that stupid machine. Only can give you a red line. So, we have a problem here. Okay. During exercise for healthy patient and the patient with varicose vein and the patient with the chronic venous insufficiency, we found this slide. Look, baseline of the healthy patient started from above 50, the blood pressure, the venous pressure in the veins, approximately arrive to 100 maybe, going down to normal, then go up after exercise to normal. In the patient with only varicose vein, you will see this trace. A classification and severity scoring of the chronic venous disease. This is what I mentioned before. International consensus, that's mean, I am talking about the SEEP. I mentioned as mentioned before. This SEEP is divided from 0 until 6. 0, the patient come to you with heaviness of legs, pruritus of leg, sometimes with pain, maybe just after standing all the day. C1, patient come to you with spider varicose vein or telangiectasis veins in the legs. When you look for this patient, oh, why you come to me? You come to me for this reason, but in fact, this is the first sign to develop a varicose vein or to develop later a chronic venous insufficiency, and maybe as in the last image with the ulcer. C2, patient, when he come to you, you will see in his legs varicose veins, nothing else, okay? Then C3, you will look for the patient, come to you with varicose vein and with edema of lower limb. It's the best thing for you to look for this patient from behind the patient, because the edema mainly around the ankle joints. C4 started to have atrophic changes in the skin, okay? C5, patient come to you with healed ulcer already, started by varicose vein, venous insufficiency, going to the ulcer sometimes, or trophic of the legs, and C6, patient come to you with ulcer at the heel, mainly at the heel. We will differentiate between the ulcer of venous origin and the ulcer of arterial origin. It's very important for everybody. Is this venous ulcer or arterial ulcer or both together? Sometimes the patient come to you with both together. This is very difficult how to differentiate between this ulcer. It's pure venous, pure artery, or both together. This is the most important slide for you and for me. Patient come to your clinic, you must put your diagnosis. The diagnosis, it will be built in this clinical etiology, anatomy, and pathology. Clinical patient, what the patient veins look like. Is there telangiectasis, spider, just only heaviness and pain? Is there varicose veins? Should you, it is a sickle of the ulcers, or there is ulcer? From this clinical etiology, whether the problem is inherited or not, ask the patient. Is somebody in your family having a varicose vein? Maybe he said yes or no. But in fact, there is 3 causes for the varicose veins: congenital valve anomaly, hereditary factor, for the woman, repeated pregnancy, and standing for a long time. There is no another thing. Okay? Anatomy, which vein are involved? It's long saphenous vein, short saphenous vein, both together. You must look for that. Pathophysiology, in which direction the blood is flowing, either normal or abnormal. We'll see that by the ultrasound Doppler, not by the vision. This is the division of our SEEP. Look, C0, patient come to you just complaining from heaviness at the end of the day, when she or when him standing all the day. Patient come to me, oh doctor, I have heaviness, pain, I can't able to tolerate my legs at the end of the day. When you look for the patient, it's normally, there is nothing on the skin. But when you send the patient to the ultrasound Doppler for examination, you will get the result. And the patient like this is. C1 means that the person has a spider or reticular veins when looking at the leg, like this is. This is a spider or telangiectasis. Mainly, this is a spider varicose vein. C2, look for the veins, and you will palpable these veins by your fingers, especially when the patient standing. C3, there is a venous insufficiency with edema of the around the ankle. Yes, the presence of edema swelling at the ankle, best visualized from the back rather than the front. And this is the C4A and B. This is also the signs of the venous insufficiency with the chronic healing ulcers sometimes. It names white, where is here, itching. It's named atrophy blanche in France, or whitish skin area, like this is. C5, already this patient did his problem and come to you with this blackish coloration at the limb. C6, patient came with active ulcer. Remember that venous ulcer always at heel or above the heel. If you're looking for the arterial ulcer, it will be mainly at the feet, at the dorsum sometimes, or at the fingers. It never be at the heel like that. And this is, we talk about this is the images. I think so. If you want, you can find that in the net. And this is your algorithm for the diagnosis and treatment of your patient. We talk about the disease, we talk about the etiology, we talk about the anatomy, and we talk about the pathophysiology. And this is the spider varicose veins with telangiectasis. This is C0. This is C3 if you want, yes, with the varicose vein. And this is C4. This is 5, and this is C6. An evidence-based algorithm for treating venous leg ulcer utilizing the Cochrane database of the systemic reviews. It's nothing new. Every day, every year is the same. The best thing for treat your venous ulcer is the medical treatment first, debridement of the ulcer, wearing stocking, 2 or 3 layers of bandage. So no need to enter in this complication. And this is a simple algorithm. Signs and symptoms of chronic venous insufficiency. You start with conservative treatment, including compressive therapy. If the patient or you satisfied by the result, continue the same treatment. That means continue medical treatment and compressive therapy. If you are not satisfied by the result, you will go for further non-invasive testing, duplex, that means ultrasound Doppler of the veins, no acute obstruction, venography. You will see what's happened to this patient, why there is no improvement of your treatment. So duplex, you are not satisfied by your Doppler, going to the venogram. As I told, sometimes there's the problem in the abdomen. One time it's happened to me, patient came to me with dilated varicose veins of lower limb. When I examined her, the abdominal examination, I found a mass about more than 20 centimeters. When she came back from CT scan, it was ovary tumor, compressed on the vein, and she came to me, her symptoms only, heaviness, pain, and varicose vein. Nobody in her life touched her or examined her for this dilemma. So be careful always. If you have a patient in your clinic, put your hand in the abdomen, please, and look if there is a mass in the abdomen. And if non-invasive, if you have the result from the Doppler, gives you reflux, that means, as I told you, there is saphenofemoral junction insufficiency or incompetence. Look superficial or deep. Consider action, or this is for foam therapy or sclerotherapy. If there is deep, go to venogram and get your result. If this is for surgery or just only for the modern treatment. I think so it's enough for that. Now, patient came to your clinic with ulcer in the leg. How to differentiate this? It's venous or arterial. Look, arterial. Look the blackish color of the ulcer. This is typically ulcer of artery. This is the processes of the gangrene, okay? And when you look deep, more deep, you will look for the necrosis, plaque necrosis of the deep tissue also, okay? Usually the patient come to you with the ulcer in the toes, the feet, okay? Toes and feet, ulcer deep, pale, skin, shiny, hairless, pallor on elevation, cool temperature. When you put your hand on the feet or on the foot of the patient, it's cold. There is no pulse. Pedal artery not found. Okay. Mild or absent edema. Sometimes there is a very mild edema. Sometimes there is no edema. More the times there is no edema. How the patient describes his pain? It's intermittent. The patient, when talking 10, 20, 100, 200 meter, then he has a cramp in the leg. He told me, oh, sorry, doctor, when I walk about 100 meter, I have a cramp. I stay for 1 minute, more than 1 minute. I relieve this pain and I continue walking. Okay. Or this is severe. That's mean even when starting walking. And sometimes it's resting pain. Patient in his bed, sleeping, lying down, having a pain, severe pain of the leg. This pain can disappear or will be improved when the patient put his leg outside the leg, outside the bed. It's improved by the stagnation of the blood from the venous system in his leg. Patient feeling sometimes better than when they put the leg in the bed. In the venous, usually around the angle, ulcer superficial, look here, the ulcer deep and pale, ulcer pink, beefy, red, irregular edges, skin leathery, brown, purple discoloration, stasis, dermatitis present, significant edema, as I told you, aching, mild pain, and pulses usually normal. When you put your hand in the pedal artery or posterior tibial artery or anterior tibial artery, there is a pulse. In the arterial, there is no pulse. And look, this is inside, just around the internal malleolus. This is outside, just beside or above the internal malleolar. This is the difference between both. This is a very simple algorithm. Peripheral vascular disease. This patient artery disease or peripheral venous disease. Peripheral artery disease is it's carotid, peripheral artery disease, peripheral renal, abdominal aortic aneurysm, Raynaud syndrome, Berger disease, or polyarthritis nodosa. In the venous, there is three things: thrombophlebitis, varicose veins, chronic venous insufficiency. I mentioned that before. And these images can tell you about what's the difference between venous ulcer or venous insufficiency or arterial insufficiency or arterial disease. Look, the stenosis, accumulation of the atherosclerosis advanced with the plaque form. This is the lumen of the artery. In fact, this is the varicose vein. Look for the valve. Valve is competent here. Here it's incompetent valve. The blood going in turbulence inside the segment between two valves. Then later this blood will be stasis in the lower limbs and the patient going to do a venous ulcers. This is the difference between venogram and arteriography. Venography, this is the venogram. Look how it's smooth, the vein. This is the deep vein. and this is the junction between the superficial vein, that means the short saphenous vein, and junction, this is the junction here with the deep femoral vein. Unfortunately, I haven't, the junction up is the same between the femoral, the long saphenous vein and the femoral vein, it's here. This is the artery. This is complete occlusion of the superficial artery. Still, this patient having a profunda artery with collaterals going to give blood to the lower limbs. This patient may come to you with pain during walking only. That's mean intermittent claudication intermittent. Why? Because the only blood going down is from the collateral of the skin to the lower limb. And this is the multiple occlusion with beaded locks like of the femoral artery. We are up to the treatment. What's the treatment? We have severe medication for the treatment. First, we have a medical treatment. We started with, especially I am talking about the chronic venous insufficiency when patient arrived at the ulcer. For the varicose vein only, we have Daflon or MPPF. For the ulcers, sometimes we use these two medications together, even with the ulcer of the venous ulcer. Why use the Trental? Why use the bentexophenone in the venous ulcer? Because the micro or macro arteries of the skin started to be occluded or stenosis. For this reason, sometimes it needs a vasodilator. And the third one, unfortunately, this drug it does not exist in the Saudi Arabia. It's excellent, can be used for artery and vein. It's named Vessel or Vessel-DF. I think so. I hear it's in Egypt also. We can find that. In Lebanon we found that. In Europe we found that. Somebody in the Argentina who invented this drug. If you have a venous ulcer or a varicose vein, it's the must to give the patient a compression stocking. It's one of the most important treatment of the ulcers. If all of these failed, or you are not satisfied after a few weeks, from 4 to 6 weeks, you have the same result, you can go to the surgical and intervention and minimal invasive treatment. We have a lot of modern treatment out now. Streaming is something, still I did that, but we have also radiofrequency ablation. We have a glue, this is the newest one, Clarivane injection. This is the sclero inside a device, and we injected that inside the vein, and the device going to turn inside the vein and inject the sclerotherapy inside the vein, and we'll put compression for 24 hours or 48 hours, and we'll remove that, the veins will appear. It's the same with the glue and the classic sclerotherapy. Type. I will stop here. We'll keep the question when Dr. Samir finishes his lecture.
Thank you, Dr. Hani, for this nice lecture.